Good morning, good afternoon, and good evening to all of those around the world who have joined us for today's webinar. My name is Erin Eckstein, and I'm the Director of the Key Populations, Human Rights, and Community Engagement team at SGAC with Pepfar. I'm pleased to welcome you to today's webinar as we get ready to kick off Pepfar's country and regional operational planning for 2022. We hope today's webinar will ground you in the overall vision and priorities for country and operational planning, as well as what to expect over the next few months, especially as we continue to remain in a virtual environment. On today's webinar, you'll hear from our US government team, including Dr. Anjali Achrekar, the Acting US Global AIDS Coordinator, Iram Zaidi, Deputy Coordinator for Program Results and Impact Monitoring for Epidemic Control, Dr. Bill Paul, Deputy Coordinator for Program Quality, Mark Jambroni, Senior Advisor for Country Management, and myself. Also, we're very pleased to welcome Maureen Malanga, Director of International Policy and Advocacy for Health Gap Global Access Project, who has been a key voice and leader among civil society organizations in the global HIV response. Before we get to the meat of today's webinar, I just want to briefly note that we do have interpreters available in a number of languages. Make sure to utilize the global icon at the bottom of your screen to select your language. This webinar also has a question and answer feature. Please put your questions there in the Q&A as opposed to the chat, as this will just help us track and locate your questions and respond to them more quickly. Lastly, please note we do have a large slide deck with lots of data and lots of information. There's a lot of key information that we may not directly present, so we may skip over some slides, but we do want you to have access to all of this information. This meeting is being recorded and will be posted on our website for future viewing. Thank you so much for your time and your attention and your commitment. And I will now invite Dr. Anjali Achrekar, the Acting US Global AIDS Coordinator, to the floor. Thank you so much and welcome.
Terrific. Thank you so much, Erin, and good morning, good afternoon, good evening, everyone. We're so grateful that you're joining us today for the COP22 Stakeholder Orientation webinar. On the next slide, please. So today, this really is a webinar, an orientation webinar for our Pepfar partners, all of you who have been invited and confirmed to attend the virtual COP 2022 planning meetings. We have two objectives. The first, to orient all of you to the overall vision and priorities for COP 22. And second, to ensure that all our partners know what to expect during the virtual planning meetings. As Erin noted, we'll cover the vision and priorities for this year's COP. We'll go through timelines, data, as well as principles and best practices to really ensure meaningful engagement. We'll then hear from Maureen Malanga, and we'll open it briefly for some questions and answers. Next slide. Next slide, please. We always start with this slide to note that we are so grateful for unwavering bipartisan congressional and presidential leadership of Pepfar. We are now 19 years in and have been so fortunate for that incredible bipartisan support that has been increasingly strong with our current administration, with the Biden-Harris administration. Next slide. Just on World AIDS Day, December 1st, 2021, President Biden released Pepfar's latest global results. This is all in the wake of COVID-19. So these results together with you and countries are extraordinary, with at least 20 countries that are at epidemic control or having reached the 90-90-90 treatment targets. Nearly 19 million people on treatment, nearly 27.8 million circumcisions that have been completed, 7.1 million orphans, vulnerable children, and caregivers receiving support, and nearly 3 million adolescent girls and young women reached with comprehensive prevention services, and 300,000 new health workers trained. These are all increases in the wake of COVID-19. So again, a real testament to your collective efforts. Next slide. When we implement COP22, this will be in fiscal year 23, a pivotal 20th year anniversary of Pepfar, a really important year for all of us 2 decades in. The reality, though, of dual pandemics of HIV and COVID-19 continue to complicate our efforts. We've been able to show, however, that with data-driven approaches, with adaptations that best support clients where they are, and continued progress with developing and working with local partners, we've been better positioned to protect and accelerate our collective gains through COVID-19. Next slide. As you all know, and we've been working with you across the globe, we've been adapting the program and leveraging the platform to protect the HIV gains and respond to COVID-19, again, in the interest of the beneficiaries we serve. The reality, though, that COVID-19 continues to affect our programs in current implementation and will as we plan for COP22. Next slide. This graph shows that over the years, Pepfar has maintained HIV treatment continuity and growth despite peaks in COVID-19. So in color, you can see the peaks in COVID-19 all throughout last year. And in the dotted red, you can see our treatment continuity and the treatment cohort continuing to increase. Next slide. And again, you can see our HIV advances in ways that we have protected and advanced the global HIV gains, while in the midst of also leveraging the platforms to help with COVID-19 testing, infection prevention and control, and other data use, as well as procurement of PPE, test kits, and vaccination, all to help protect our HIV gains. Next slide. So our focus is really to maintain our gains and evolve the programs as needed during COVID-19. In countries striving to reach epidemic control, we must continue to address programmatic gaps, be resilient, and continue to protect and address safety during COVID-19. Again, the adaptation of programs have been really critical to conditions that have been changing. In countries at or near epidemic control, our work is not done. We must still achieve 95, 95, 95. Again, there's been remarkable progress in driving down new infections and mortality, and you'll hear more from Iram around this, but you'll also hear that there are gaps. There are critical gaps that we must address among children, young adults, adolescent girls, and young women in key populations. Epidemic control is a dynamic state, and this is something that we have to monitor very, very closely and ensure that sustained HIV impact is what we're all seeking together. And this is a long-term gradual process. Next slide. As we look to the future and as we look to COP22, you'll hear from our colleagues throughout the presentation how community-led monitoring continues to be essential, empowering local key population and women-led organizations, again, essential. Quality improvement and people-centered design are critical. Peer-led prevention and treatment services, gender equity and efforts to focus on increasing services to key populations and adolescent girls and young women, and enabling environments, policies that are ensuring system services and capacities are in place. Next slide. There's a fourth new pillar that we have added to our efforts to controlling the HIV pandemic. In addition to accountability, transparency, and impact, we've added equity, and you'll see this through COP22 guidance and in the presentation that continues. Next slide. Core operating principles and values that are highlighted in COP22 include the following 10: local ownership, person-centered care, evidence-based, data-driven decision-making, a focus on diversity, equity, and inclusion, gender responsiveness, collaboration and partnership, agility and adaptability, resilience, and linkage and integration. Next slide. So you'll hear that our vision and implementation for themes of Pepfar's COP22 are in 3 categories. First, to accomplish and finish the mission. The second, to building enduring capabilities. And the third, to building lasting collaborations. With that, next slide, please. I'll turn to Iram, who will cover Pepfar's contributions to global and country goals. Iram?
Good morning, good afternoon, and good evening, everybody. I have a lot of information in my slide deck. I will highlight key pieces, and as Anjali and Aaron mentioned, these data will be available to you, and they already are on pepfar.gov. So please look at our data country by country in more detail. And I preface all of my remarks with, up until the information we have today, these are the pieces that we come to understand globally and the impact that we've globally had together across the world in combating new infections. In 2010, globally, we were at over 2.1 million new infections worldwide. Over that 10-year time period, we've drastically reduced those new infections. And in fact, the most impact that we see is East and Southern Africa. Next slide. And as you go through, so these data are really important as you are engaging in at a district level, at a site level, at a community level, at a population level to say, all right, where should we be focusing now? You know, there's clear work to sustain and making sure everybody who's on treatment is virally suppressed, has access to services in a user-friendly manner that meets their needs. But where else do we need to be focusing? And these data on the distribution of new infections and the next slides that I'm going to go through show you by population where new infections are coming from. So as we are trying to sustain HIV impact, looking at this by age and sex, really critical. What you see, and I'll get into some of the details in just a moment, but these countries, Mozambique, Nigeria, Zambia, Tanzania, and South Africa, and the big donut at the top, are countries that have not yet reached 90-90-90, and they're all, in effect, decreasing new infections and all-cause mortality. And you can see the number of new infections are twice those of those countries that have gone beyond 90-90-90. So these are important concepts to then operationalize in our programming. Next slide, please. And hopefully everybody saw the amazing progress that came out of the Botswana and announced the Botswana Fia Survey last year, where nationally in Botswana, over 91%, 93% of individuals living with HIV in Botswana know their status. And then, as we've discussed already, they're on treatment and they're virally suppressed. And just, it's amazing collectively as we plan programs and implement programs, what we can achieve together. Next slide, please. But the pieces that still persist, and we've been talking about this for a number of years now, is our 15 to 24-year-old populations. And these are the populations where new infections are more likely are occurring, where lifestyles are very different than older adults, as myself, and making sure we have programs, particularly in the wake of having 40% of the population under 15, 30% of the population under 15. So again, as you plan and you look at the details in each of the country operational plans that you're engaging in, please bring your insights to the discussion and to the table about how we address such a critical population. Next slide. And we're at a point in time where we can look at what is the impact, excuse me, in countries that have reached epidemic control and those that are still striving to get there. So this is a really important slide showing new infections among females 15 to 24-year-olds. On our left, we have new infections among females in this age cat in this young group on the left, and those on our right are in countries that are not at epidemic control. And you can see such an important trend in new infections being halved over this time period in these countries. So epidemic control just isn't an epidemiologic concept, but it is preventing people from getting infected with HIV. And that detail level information about where are these services for case finding, for prevention in each of these districts. And perhaps as we have more and more new data about where people are migrating to, what do cities now look like in countries like Kenya and Uganda and Zimbabwe, Zambia, really bringing your experience, your local experience about migration, job opportunities, where are those economic growth that people are seeking, and moving into different places around the country to maintain and continue to drive down this impact. On the countries on the right, and South Africa is in the inset because it's just the number of new infections are persistently much higher than the other ones, including Mozambique, Uganda, Nigeria, Tanzania, and Zambia. But you see that the new infections are just stalled. They do not decline as they are in the countries at epidemic control. And my next few slides will look this in a similar format. Next slide, please. So these are males. So again, countries at epidemic control on the left, and those that are not yet at epidemic control on the right. And if you remember the graph on for females were much higher new infections, still that inequity persists. However, the number of new infections and the trends are declining for men as well. Next slide. And so as we look at the pediatric gap and closing that inequity on pediatric infections, generally speaking, again, much progress. And we're at a point where we need to be looking at individual level information to say, where do these inequities persist and how do we address them? So as we look at closing the pediatric gap, I wanted to highlight where these gaps persist by age group. And we see that those above 5 years, and particularly those above 10 in South Africa, Mozambique, Uganda, are really the key age groups that we need to identify. We've had such remarkable progress in PMTCT, the number of infections through mother-to-child transmission has remarkably reduced. So we need solutions now for these specific age groups. Next slide, please. And this one is just phenomenal, translating this epidemiologic concept now to orphanhood due to AIDS. And it's not a surprise, but now that we have the information about the countries that have identified ways to keep people alive on treatment, reduce new infections, the number of orphans due to AIDS has declined dramatically. Unfortunately, we see high levels of orphanhood still persisting in the countries that are not at this place in their epidemic. So again, bringing all of this information to bear and understanding that scaling up 90-90-90 is such a critical intervention to then see these declines and really community impact across the board. Next slide. So I won't go through these country by country, but I will just touch on each concept and kind of give everybody, depending on which country you're in, like the high level focus. So these countries that are at epidemic control and have had community viral load suppression, again, UNAIDS goals of 73% community viral load suppression. Next slide, please. This goal is really looking at where are new infections coming from? How do we address them up front? Do we have the right case finding modalities? Are we able to find the 15 to 24-year-old population beyond PMTCT? And do we have prevention and VMMC at the levels that are necessary to maintain the decline in new infections and mortality? Next slide. And we can go to, yes. And so on this one, in next slide, these are countries that are at epidemic control, but they got there because of mortality increases. So scaling up 90-90-90 is the critical intervention. Next slide. Next slide. Countries that are near epidemic control and near viral suppression. Next slide. We need to scale up 90-90-90, and you'll hear very clearly about how these countries are moving forward. Next slide. And then those that are having a decline in new infections, but are not net at 73% community viral load suppression. Next slide. And so really understanding the barriers. Are there policy barriers? Are there operational barriers? What are the barriers that are persisting down to the site level where these countries are not achieving the success that we see other countries can? Next slide. Next slide. Next slide. So all of those slides are available for you to then look at your own countries and where you're engaging in the COP process. And I just wanted to touch on sustaining HIV impact. And based on the progress that we've shown across multiple countries now, we wanted to start this engagement on sustaining HIV impact and what does the program look like. There will always be external threats to maintaining HIV control. But we also realize that we need to evolve our program to meet the needs of today's epidemic and not where we were while we were still scaling up to 90, 90, 90, and 95, 95, 95. So we're starting with a subset of countries, really engaging at the country level through government and civil society and kicking this off in this COP process. We want to hear everybody's voices around the table. But what I also want to recognize is that through all of the information that I've just discussed, our disease burden and the number of people living with HIV have stabilized over the past 4 years. We're not in a position where we're still having increased numbers of new infections. Next slide. And so, as Anjali mentioned in the beginning, when we're talking about sustaining HIV impact, and I know there are a lot of different interpretations on sustaining and other terms, but our work is not done. This is a dynamic state, and as I discussed through the data, really focusing on new infections and mortality among people living with HIV, preventing mortality, we see that, addressing the gaps among children, young adults, adolescent girls and young women, key populations where these inequities still exist. And it's a dynamic state. And we have to understand and set up the systems, the structures that can work in this dynamic state. And the expectation is that the budget would not go to zero. This is a long-term process and want to work in partnership at that site level for this evolution. Next slide, please. And so there's more information here, and I imagine as we get into the COP discussions in these specific countries, we'll have a deeper discussion around each of these concepts, but really having an understanding of what are we trying to attain, having that shared approach, enabling environment, and you can see some more of these details when you have the slide deck. Next slide. And this is an iterative process. So we all know plan A is never the plan that succeeds. So we need plan B and C, and we will continue to evolve together. Next slide. So with that, let me turn it over to Bill Paul. Thank you.
Thank you, Iram. Hello, everyone. It's good to be with you. Next slide. Each year there are themes, strategic direction. Anjali has mentioned the themes for COP22, accomplishing the mission, building enduring capabilities, and building lasting collaborations. Next. The COP guidance is a long document. It's detailed. The first 2 pages present what's new in COP guidance. The only thing I'm going to highlight here is that we're starting to shift language from client-centered to person-centered. We know it's important to get language right, but we also know that that takes time. Next. We define equity. We talk about an equity lens, which prioritizes actions that reduce inequalities and advance equity. And this includes actions to address the underlying social determinants of inequality. As we go into COP22 and ROP22, pay attention to plans for children, for adolescent girls and young women, and for key populations. These are global priority populations where equity efforts are highlighted in COP guidance. Next. We always begin with the end in mind. So in section 7 of COP guidance, we talk about planning, and we plan with viral suppression as the end result. And you can find out more there. Next. As countries attain epidemic control, they need to be assessing gaps, addressing equity, and adapting, because things change as you get closer to epidemic control. Next. One of the key elements to pay attention to and highlight a priority in ROP22 is human rights. And there are specific actions we're asking teams to take to advance human rights and make sure that our interventions, our operations are responsive to human rights concerns. Next. Next, minimum program requirements are familiar, and they're a core part of our guidance to country teams. The first 2 pages are the same. Next slide. Next slide. We have 3 changes this year. One is a new minimum program requirement that is to demonstrate evidence of progress towards advancement of equity, reduction of stigma and discrimination, and promotion of human rights. And the second update is to add infection prevention and control and site safety standards to our quality-related minimum program standards. And then finally, the local partner funding requirement is enhanced to include increased funding for key populations-led and women-led organizations. Next. On our first goal, which is to accomplish the mission. Next. As I said, we have to address the population gaps. And so here are some things to pay attention to in the three populations that are a focus globally. Next. For closing equity gaps in pediatrics, Hiram covered this well. There are 7 countries with the largest gaps and we're asking them to have specific plans that are budgeted to move towards closing those gaps. Next. For gender and adolescent girls and young women, there is a new focus on gender equality, which stresses norms change and gender transformative activities, gender-based violence services, and updates to the adolescent girls and young women and DREAMS guidance. Next. Key populations, of course, is growing in its importance as overall success is occurring in HIV epidemic control. Next. Our approach for COP22 is to continue to focus on what has worked well, to improve data. This is a challenge to make sure that our size estimation gives us a good sense of where we need to be and helps guide our program, to expand community-led monitoring specific to key populations, and to really respond to challenging, enabling, and policy environments and structural barriers that impede scale up of KP-led and competent services. Next. In terms of testing services, next. This shows modalities by country, and you can see in orange towards the bottom that index testing is a very important mode across many, if not most countries. Next. The change this year is that there's not a percent of positives from index testing that's required, but we're requiring a universal offer. Safe, ethical index testing should be offered to all who are eligible, and that testing plans should really be strategic and adapt as countries approach treatment saturation. Next. There's further guidance on what types of approaches to testing might look like as countries get closer to epidemic control. Next. In terms of prevention services, next. We continue to support voluntary male medical circumcision in these countries. Next. We also are encouraging scaling of PrEP, and there's been great success with scaling of PrEP among key populations and others. Next. And we're talking more and more about a HIV status neutral service delivery model, where if you're at risk and your HIV test is negative, you're encouraged to engage with prevention, including PrEP. And if you're positive, you're encouraged to engage with treatment and continuous treatment. Next. Continuity of ART continues to be a really high priority and a challenge. Next. 2 key points to pay attention to are linkage, making sure that that first linkage is durable, or we call it sometimes sticky linkage, but also to anticipate and plan for treatment interruptions. Interruptions do happen, and so we need to have a robust and friendly welcome back to care approach. Next. One of the key interventions for continuity that has scaled significantly during COVID has been multi-month dispensing, which really enhances convenience and continuity for our customers. Next. Viral load coverage is important to pay attention to. This shows a wide range in results for viral load coverage, as well as change in viral load coverage from quarter to quarter. Next. Another thing that's happening in Pepfar is as we succeed, an increasing number of people are living longer. And so in many countries, 1 out of 4 people living with HIV on ART are above the age of 50. And that will continue to progress. And as we plan, we need to pay attention to the needs that emerge as people age. Next. Building enduring capabilities. I'll go super quick here. Next. I think this has been well covered. Sustainability doesn't happen overnight. It includes both functional responsibilities and fiscal responsibilities. Next. There's an analytic framework, which includes the responsibility matrix, as well as the resource alignment. Next. It's important to pay attention to public health capacities in countries as they move towards sustained impact. Next. One of the important capacities is information systems. These should not be siloed. They should really serve the client and be viewed as enduring capabilities for the country. Next. Recency is an important clue in terms of understanding where new infections are occurring. Next. Leadership capacity, functional systems, and supply chain also are really critical as we move towards sustained epidemic control. Next. The COVID response has been covered well. Safety for staff and clients, using the platform as we can to strengthen the national COVID response. Next. And this is the last slide. This is about local partner services. And the story is there's been really good work done, but there's more yet to be done. And with that, I'll turn it over to Mark Jambroni.
Great. Thanks so much, Bill. So hello, everyone. My name is Mark Jambroni, and I currently serve as the Senior Advisor for Country Management here at SCAC. And I'm going to be speaking to you today about the importance of collaboration with our key partners during the COP22 planning process. Next slide. So for COP22, teams have been made aware of the expectation to actively engage stakeholders in all aspects of strategic planning. This includes being briefed on timelines and process for tool review, as well as knowing the various opportunities to insert feedback into the COP22 strategic direction. For each Pepfar OU, teams were required to conduct strategic retreats with local stakeholders to introduce and discuss all COP22 tools, guidance, results, and targets. This process occurred the first 2 weeks of February. This conversation will continue during the planning meetings. In large part, will occur the weeks of March 7th, 14th, and 21st. So following COP22 submission, Pepfar teams are required to continue engagement with stakeholders through the routine sharing of data through our report process. But please keep in mind that each country has a different process for routine data sharing, which may occur outside of the report process. But at a high level, guidance to field teams is to ensure data is shared throughout the year, not just during COP planning. Next slide. So throughout the years, the COP process has evolved to be more inclusive of our partners outside of the US government, and our program is better for it. So at every step of COP planning, the collaboration with partner governments is critical to ensuring that our strategy for reaching epidemic control is translated into action. So civil society. So we need CSOs and community organizations to be extensions of our program, ensuring our priorities match those in which we serve. Now that CLM is being implemented in many countries, we have started to be more intentional about community-led implementation of our programs. So next, our strong partnerships with the Global Fund, UNAIDS, UNICEF, WHO, and others have played critical roles in our collective success in many countries. Aligning our efforts and benefiting from each of our comparative advantages have changed the way that we implement our programs. And lastly, the private sector. As more and more countries reach the cusp of epidemic control, our private sector partners will help Pepfar foster innovation, ensuring that we maintain the gains we've made over the past 19 years. Next slide. So speaking specifically about the Global Fund collaboration, personally having just come from the field, I learned firsthand the importance of creating and fostering a transparent relationship with the Global Fund program. This extends to the CCM, the principal recipients, and the fund portfolio manager. Being better aligned in our efforts ensures that we are on the same page during the various planning cycles and that we are using the same data. Additionally, the Global Fund continues to implement and make resources available for C19RM. It is the expectation of Pepfar to ensure both our efforts are complementary. Next slide. So I will next go over the COP22 timeline. Next slide. So outside of the COP planning process, our teams meet to review and discuss data on a quarterly basis. As mentioned earlier, many country teams share this data with civil society and other stakeholders outside of our official processes, which is great. That said, we will have an opportunity to engage on the official Q1 discussion during day one of the COP22 planning meetings. This process enables us to monitor progress across program areas and troubleshoot issues, making real-time changes to our program. So as we move further into the COP planning process, teams have begun to plan and budget according to the strategic direction laid out in the planning level letters, which I'm sure many of you have seen, as well as the key principles described in COP guidance. Next slide. So similar to last year, with the reality of COVID, COP planning and finalization will for the most part happen virtually. Bilateral programs will participate in one of 3 groups this year. Regional platforms will have a longer and more flexible time frame to ensure teams can finalize planning and tools. Sustaining impact OUs, which will be Botswana, Eswatini, Lesotho, Namibia, Kenya, and Uganda, have additional guidance and longer timelines to finalize their tools. Looking at the top visual here, you can see that we are well underway with the COP retreats just ending on February 11th. Our next official engagement with field teams will be the opening plenary, which will be this coming Monday, February 28th, where we will officially kick off the planning meeting window. The planning meetings are split between 3 weeks, March 7th, 14th, and 21st. The country groupings are listed in COP guidance, and a final version has been put on our website as of yesterday and can be found under the COP22 resources page. These meetings are meant to be 3 half days with ample time for civil society and other key stakeholder feedback. We also want to take full advantage of the virtual nature of these meetings and be inclusive and impactful as possible. So after the conclusion of week 3 of the planning meetings, we will start the closing plenary on March 28th, and then a 5-week window where teams can start to submit their final tools to SCAC for review, and then subsequently have their approval meetings. Similar to last year, planning meetings will occur only when the tools have been sent to civil society and stakeholders and then finalized. There's a lot of flexibility on the back end of the planning cycle this year to allow teams as little or as much time needed to successfully complete the COP elements and have the approval meeting. The bottom visual here outlines the sustaining impact OU timeline, which matches up exactly with the other OUs, with the exception that we will be allowing more flexibility. For planning purposes, these countries have been placed in various country groupings, with the majority going on week 2 and week 3. Next slide. Moving on to country groupings for this year. Like I mentioned earlier, all the countries will be split into these groups here. There are a few exceptions due to extenuating circumstances. This can be seen here with Group 0, which has been created to accommodate Ukraine and Zambia, who will be conducting their planning meetings 1 week early to accommodate their country context. Next slide. Post-planning meeting, teams will begin to finalize their COP, and each country grouping will submit according to the dates above. Next slide. So these are some key webinars and plenaries taking place over the coming weeks. Just like in previous years, we will host 2 stakeholder and civil society town hall webinars, the first round on March 10th and the second on March 23rd. So depending on what country grouping you fall into, is what town hall you will attend. Once we here on the logistics team receive all of the delegations, we will comprise the invites to all civil society on the delegations and invite them to attend the town halls. The same process will be for government partner meetings. So lastly, our closing plenary will take place on March 28th, and this will officially close out the planning meetings. Next slide. And with that, I will hand it over to Erin Eckstein.
Thank you so much, Mark. I'll now just take a few minutes to conclude the U.S. government portion of today's webinar by emphasizing a number of principles and practices that ground our approach to COP and ROP22 planning virtual meetings. Next slide, please. So first, just to start, I just want to emphasize and ground us that stakeholder engagement and consultation is a key value of our Pepfar-wide efforts. And this includes, as Mark already illustrated, working with partner governments, civil society organizations, communities, as well as multilateral and private sector partners. Next slide, please. As with our virtual meetings last year, I want to note that our approach again this year will be 100% virtual, and we're emphasizing inclusivity and flexibility. Unlike with our in-person meetings, which many of you may have attended in years past, there's not a standard schedule or agenda, and it's important to note that teams will not meet every day of any given week, and they may have different hours. Weekly agendas, however, will be provided by the country-specific teams. Given the challenges around staying present and engaged for many, many hours on a virtual Zoom or other platform, the meetings will be shorter than they were in person, and so we'll emphasize prioritization of key issues and opportunities for feedback and dialogue with stakeholders. Next slide, please. As noted, we'll be using the virtual meeting platforms, primarily Zoom. Each of our country teams has a dedicated coordination team, and they're responsible for creating the calendar invites, sending out meeting links. Those have started to go out based on the country grouping. So as a registered delegate, you should expect to see those soon if you have not already. We have increased overall the stakeholder delegation sizes, really to take advantage of a virtual platform. And at the same time, we want to ensure that discussions are productive, manageable, and that all stakeholders have an opportunity to share their views and participate fully in the discussions. Next slide, please. I think actually in the interest of time, I'll go ahead and skip this slide. Next slide, please. I just want to share here, the next few slides are a list of more detailed considerations specifically for civil society engagement that we've provided to Pepfar staff, both at headquarters and the field, including chairs, PPMs, and our Pepfar coordinators on the next slide. And these recommendations have stemmed from direct feedback provided to us at SGAC as part of last year's after action review from agency specific processes, and from the input that many of you have provided in reviewing our draft COP guidance. I won't read all of these here, but I do want to note here, actually, if you go back one slide, I do want to note here suggestions here for building multiple points in the agenda for CSO representatives to provide comments and priorities. And again, we have kind of a list here that we've shared and that we strongly recommend to our teams. Next slide, please. Similarly, these are specific recommendations to our field-based Pepfar coordinators. We've provided them delegation guidance that there should be representatives from diverse grouping of local CSOs with specific requirements for people living with HIV, key populations, adolescent girls and young women, and faith communities. So organizations that represent those constituencies as well as others. Next slide, please. Also here, just want to emphasize, again, I won't read all of these, but noting here, just want to emphasize in particular the need to ensure engagement that is not just limited to the COP development process, but that we really do expect regular ongoing engagement at minimum quarterly, as Mark articulated as part of our quarterly review process. Next slide, please. We know that we've provided you a lot of information today. A key question that we often get is, how should I prepare? And we've provided here a number of recommendations on this slide about how each type of partner can utilize their perspective and expertise to contribute to COP planning and really making the best program that we have for Pepfar. Next slide, please. Lastly, I just want to conclude by sharing a consolidated list of resources and links for information. The first link is really foundational information and country-specific documents. We also have a link to COP guidance. As Ira noted at the beginning, we're very focused on data, and so our Spotlight public-facing data website is there. I also want to draw attention to the COP and ROP22 landing page, which will have, as Mark noted, all of the latest information on resources, on schedules, and as Mark noted earlier, we have just provided updates on the country groupings, as well as more specific week-by-week calendars. So with that, I'll conclude the US government portion of today's webinar. And now I'd like to invite Maureen Malanga to the floor, to the virtual podium. She's Director of International Policy and Advocacy at Health Gap and a key stakeholder. Maureen, over to you.
Thanks so much, Erin. I'll just jump right into it. Thank you for the opportunity to present here. We are presenting the views of Pepfar Watch members. We had a series of calls this year, I think about 12, with hundreds of civil society who really wanted to join and be part of the Pepfar process. So we're really appreciative of the space to share our thoughts as civil society. Next slide. So what's at stake for civil society this year? We can see the colliding epidemics between COVID, HIV, TB pandemics that have caused great harm. We are coming into the room to have a discussion about the disruptions in treatment that we've seen and prevention services, and the areas of human rights violations that we could see from our community members, and the challenges that have been caused, stockouts for people living with HIV and key populations. We have had challenges that have been raised at a community level about lack of access to services because of not having masks, or services that have, in essence, stalled, like support groups for people living with HIV, because we were implementing the COVID protocols, which were important, but then we ended up not supporting some of the community groups. So we are trying to figure out how do we support those community groups while still maintaining those COVID protocols. It was really great to see innovations like 6MMD in the countries that did them. They showed great promise. People living with HIV liked them. And we really want to have a conversation about how we expand and maintain those. We also want to share that from our conversations that we still see that we are far away from 95 goals for all countries, and sustained epidemic control among certain population groups. And I think for us, coming into the room, we think finishing the job is about reaching 95 for all ages, all genders, and all communities. We are also coming into the room to have a discussion about sustainability, which to us means increasing the momentum on things that we know we have done right and we want to expand, and not having a plateau or a reduction for countries that have reached epidemic control. Next slide. So the other thing that we wanted to have, we're going to be having a conversation about is budgets, things that need urgent repair, scale up, and accountability to communities, such as key population budgets, like the key population investment fund, that from most of our conversations with communities, we see there's no follow-up strategy. There wasn't a way of really adopting some of those activities that were done by communities. We also want to have conversations about new tools, service delivery approaches that we want to scale up, and not like have a conversation about where we see flatlining and reduced budgets that we see will undermine access to services and progress people towards death. Next slide. I think I've already said that. So in terms of treatment and care, most in our conversations, there was a lot of conversation about how there's still quite a few areas of poor quality. We have challenges with staff attitudes, stockouts, long waiting times. We really want to see an expansion of treatment literacy that is implemented by people living with HIV. Right now, most of our treatment literacy is implemented at the site, but we are also offering people 6MMD. So they are no longer coming to the site as much as we would love to see them. So we need to have programs that have treatment literacy that is implemented by PLHIVs and KPs at the community level. We also want to see more DSD We want to see people living with HIV and key populations being given priority to roll out cadres, to be part of the cadres of community health workers and mentor mothers, which we see in certain countries. Mentor mothers are not actually women living with HIV, and we want to fix some of those. We would love to see a prioritization of ending preventable deaths from TB, cryptococcal meningitis, cervical cancer. We want to see also a discussion about scaling up AHG and hearing what programs are doing around AHG programs, and a discussion around medicines that treat and prevent cryptococcal meningitis. Next slide. In terms of prevention, we have been having quite a bit of a conversation over the years since we began index testing about how to do safe and ethical index testing. And one of the areas that we really want to see is that communities have shared data on where index testing sites have been assessed, where they are failing, what action is being taken to prevent adverse effects. We also want to have community demands that reshape. We have our community demands that have reshaped index testing in the places where it has been taken up. But most of the time we see countries agreeing to those recommendations, but not necessarily taking them up in practice, and we'd like to see that. In terms of recency testing, we would love to see community consultation. We know this has substantial costs, and we are worried about whether the impact is limited, and we need to have a conversation about how best to do recency testing in a way that we have community consultation and we see where best to put resources. We also need to have a conversation about PrEP expansion across countries. We see demand, we see young people wanting key populations, women who are pregnant, and we really need to see an expansion on those. And also to conclude this slide, I think one of the areas worth mentioning is condoms and lubricants. Across multiple countries, we have asked communities, and we cannot see condoms and lubricants in the sites. They're out of stock, and we really need to have a conversation about how best to provide those. Next slide. So under perinatal prevention and pediatrics, like I said, PrEP for HIV negative pregnant and breastfeeding women is really something that's on our minds. We really want to have a discussion. We want those across countries. Point of care early infant diagnosis is something that we've asked over the years. We see many delays from conventional EID testing, and we want to move to a space where mothers have results immediately so that children can have access to treatment. We want an expansion of mentor mother programs that are led by women living with HIV and support for women living with HIV and their children to ensure quality services and viral load suppression. Next slide. So with regard to key populations, I think this is where we see that the 95 targets are a dream. We really need to see that programs are funding to fund shifting to fund key populations. We put out a strategy for key populations. You can see it here. We really want to see countries think about how to adopt some of those things that were being asked for by communities, and also fund advocacy to address stigma, which is really big. Also, among our harm reduction programs, we see Pepfar had begun the program, really did well in setting it up, but now across countries, there's really very little increase in the support that's going to harm reduction programs. And we'd like to have a conversation about how to do that better. Next slide. For our West Africa partners, I think the key things that were raised were about the lack of progress on 70% localization of Pepfar programs. We can see across through USAID that there's virtually no local partners that are funded. And we can see some global partners actually just registering as national partners to then get around accessing resources. And we want to see an actual shift to community-led processes and country-led processes. So in terms, next slide. In terms of the planning process, we've really struggled with the virtual planning, and we are hoping for a return of in-person meetings. And we really need meaningful engagement of communities that's just tokenistic. And apologies, there is a typo in my texts, but yes, the bad practices that we saw in COP21, we hope to be corrected this time for this COP. Next slide. In terms of funding, we are a long way from sustained epidemic control. We have many challenges with funding. We are unable to ask you for many things when there are no resources to actually program. Every time we're coming in, we have new ideas, we have new thoughts about how to do this better, but there's no resources. So we really need to have a conversation about how do we repair the damages by COVID when we really don't have those resources, and how do we have a conversation about resources. Next slide. With regard to community-led monitoring, if you have not heard about it, it's communities leading the monitoring of quality services. It's a great opportunity for communities to be part of the process and also share their recommendations about how to improve the quality of services at a country level. It's community-led. We go, we collect data, we compile it, we analyze it, we come up with recommendations, and we share those recommendations with duty bearers. Next slide. But with the challenge, one of the challenges that we faced is that we have very little funding across going to our community organizations to actually do this. We are hoping to make sure we maintain independent community hosting and community coordination. We want to make sure that we are grateful that CLM is being considered as part of a minimum program requirement. And we hope that comes with funding that is allowing communities to truly do this well at a community level. Last slide. These are the People's COP from last year. Please look out. We are going to be sharing our People's COPs for this year. Yes, thank you.
Thank you so much, Maureen. I think we always appreciate how you're able to pull together kind of diverse recommendations in a very concise and focused way across many different people who I know input into this, as well as covering a wide range of the different technical areas that builds an HIV program. So we appreciate that. Thank you. I also see a number of comments in the chat, either agreeing with you or also adding their recommendations. So we only have just a couple of minutes left. And there's no specific questions in the Q&A box. But what we are going to do, as time permits, I see there are a couple of attendees who have their hand raised. So what I would like to do is ask if Ishad Jan, if our wonderful technical facilitators can help Ishad get off mute, and the question can be asked.
Long-term investment by countries in their partners, including the global fund, was critical to mitigating COVID-19.
Sorry, I think we're having trouble hearing.
Investment in community health workers.
Hi, sorry, that was a mistake. My hand was raised by accident. Sorry.
And fighting against other health threats around the world. Malaria is a disease of poverty.
Okay, thank you. Yeah, still I hear some other background. I'm not sure what that is. I do see we have Smita Ghosh has a hand up, and I'm wondering if that person can be taken off mute to ask their question. Thank you.
I'm sorry, Erin, that's a mistake. I have no questions. Thanks.
Oh. Sorry about that. We have a couple of those, don't we? I do want to ask, I see one question that has come in through the chat. It says, does Pepfar have an expected cost for the recency testing program during COP22 implementation across all countries? From Brian Honerman. And I'm wondering if, Iram, if that is a question that you might want to tackle?
Sure. Can everybody hear me okay?
Yes, loud and clear.
Okay, great. So thanks for that question, Brian. And we ran out of time, but there is key information that is coming out about from the implementation of our recency program. that is important. We can put it out on our website as well. And I think you'll hear it in key countries as you go through the COP process. The intention of the recency testing, and let me just start as an overview, is to understand the patterns of new infections. Where are they coming from? So as you think about the slides that I presented about new infections by country and by age group, those are all coming through our surveys, through key population surveillance, but we don't have anything that is routine on an individual basis while people are getting diagnosed. Those surveys, such as the FIA, the behavioral surveys among key populations, we all know don't happen frequently enough. We all know that they're very expensive. We all know that they're very difficult to execute. So we need to have routine data that gives us clear information on a nearly daily basis on which way do we need to be focusing our prevention programs. So the recency testing, and we're making the best use of the tools that we have. And global prices on all of our commodities are increasing because of COVID impact, inflation, everything that we're facing. But we need to make the most utilization of the tools that we have in hand. And as we've been implementing recency, what we have been finding are two things. One, that among those that we have been, and we're not even at scale on every positive, every consenting positive, but that we know this anecdotally, but we have probably about 50% or more of people who are tested on an annual basis are repeat positives. In fact, they may be treatment experienced individuals. So when we're trying to laser focus on preventing new infections, we're sidetracked through some of our routine program data. So recency on top of our routine program data is helping us to filter out where are we actually implementing our programs. Are we in those 15 to 24-year-old treatment naive, prevention, high-risk groups? Are we in those specific key population groups? And now it's also giving us information about patterns of new infection. So our expectation, and we're at a point where we need even more precise information to effectively utilize all of our resources, our human resources and our financial resources, just as Maureen outlined in her points from civil society. Our expectation has been for several COPs that we are at scale. COVID had a 2-year impact on the delay of getting recency scaled, but we need it in every single site. And people ask, well, could we do Sentinel Surveillance? Could we have recency implemented in a select sites? And what we have found from Sentinel Surveillance is an overestimation when we did, and again, these were the tools that we had and we started with. For example, in Nigeria, when we did Sentinel Surveillance among ANC clients, we overestimated the disease burden in Nigeria by almost half. So when the FIA results, again, difficult to execute survey, important survey, it gave us a whole different understanding about the disease burden in Nigeria. But when that came out, we realized we had a different epidemic that we were dealing with. So recency, or tools to understand where new infections are coming from, have to be on every consenting, whatever the local context is, whatever the government and civil society agrees on, should be the implementation and operational model. But it can't be just at the facilities, right? Because we know that the facilities have a certain type of clients that come. So we don't want to get back 10 years behind this virus because we had blinders on in the way we were implementing our program. Thank you.
Thanks so much, Iram. So we are just a little bit over time, noting that there are questions and comments in the chat that we won't be able to get to and wouldn't be able to do justice to in a very quick format anyway. But I do see here, there are noted here, I think, things that we need to further consider and deliberate both as we think about Pepfar going forward, but will also be important discussions in the country-specific meetings around PrEP, around how we are doing target setting for transgender populations, the intersection between Pepfar and COVID response, and a number of other concerns and questions and points that have been made in the chat. So I think all of that is extremely valuable feedback that we're going to compile and really note as key issues that we need to think about going forward. So with that, I'd like to conclude our session today. Again, we want to thank you for your time and attention, and we're really looking forward to a successful COP and COP22. Thank you so much.